okay, he's a patient, has a cardiac arrest, and you show an electrocardiogram, show ST depression, which could be, who knows, related to the shock or could be ischemic. But it has been a great controversy in the literature that after cardiac arrest, should you do a cardiac catheterization? And here's my first question, because the guidelines say if the patient is not unstable, you might wait for about few days. If the patient is unstable, you should do a cath right away. So my first question, before we go into the type of modality that you use to open this artery, is do you think was appropriate to do the catheterization right away?
If I could say something, I was wondering in the case after a cardiac arrest with the prior clinical history of the patient, maybe now it's easy to have access even to a pocket echo. Why rush to the cath lab now have more information about the patient, about what is going on with the heart with an echocardiography? This is one of the burning questions after this kind of cardiac arrest. We don't have pulse activity, so maybe it could add more information what to do. Maybe you have a chest enlargement on the X-ray. Maybe there is something going on with the pericardium. I don't know. I think I will not rush to the cath lab and get more info with an echo. I don't know what the other members of the panel
Yeah,
think.
I can only say to you that if you go to guidelines, there is a question here about this patient having done so early. However, there's an article on JACC actually published from a group in Switzerland 3 weeks ago. Now that you did the right thing, because some patients that appear to be stable, they have coronary occlusions, and therefore you should open up as quickly as possible. So you are targeting a patient with a reasonably stable condition after cardiac arrest. 1 out of 4, 25% have a coronary occlusion. So to wait is not worth it. So I think the right thing was done. Now comes the second question. Yeah, any comments?
Yeah, the way I would look at it is the need to rush to the cath lab is ST elevation. So most papers say that if you don't have ST elevation MI, taking to the cath lab doesn't seem to change overall cardiac arrest outcomes. But here there was more than that. The patient was complaining of active chest pain. There is ischemia in pretty much every lead, and it's pretty significant ST depression. The AVR elevation kind of raises the question, is there multivessel disease or left main? So I would be very uncomfortable not taking him to the cath lab. So that's what I would do. But I also agree there is enough time for us to get a quick echo and see what exactly is happening. And that would be very useful.